Can I ask you a question real quick? So we'll talk about the 3-centimeter tumor. You're not really worried about the liver. So are you dosing to the perfused territory?
Yeah.
And what kind of dosing are we looking at with you? Like what kind of dose are you looking at treating with? What kind of activity are you ordering?
So if you're talking about a scenario, let's say you have a 3-centimeter tumor, you do a mapping angiogram, you're able to do what's called a radiation segmentectomy, which there are different definitions of a radiation segmentectomy, but in general, I think most of us agree that it's like equivalent to one Queenot segment or less, right? Some of the original definitions were a little bit more broad. Let's give another example. The patient is Child-Pugh A, okay? We're typically looking at a dose of the entire perfused volume of 400 gray or higher. And that was based on some of our explant data done about 3 to 4 years ago, where once you hit 400, your rate of complete path necrosis approaches 100%. So then the question becomes, well, is 500 better than 400? Is 600 better than 500? How high? What about 10,000?
That's
right?
So options. You have options, and where do you
pick? To be honest, we don't know. We have no idea. We never really did that kind of dose escalation work. Anecdotally, in my own practice, I'm probably shooting in the area of 600 to 800. Is that the right answer? I don't know, but that's just what we do. And we have not had any major downsides in terms of toxicities by going up to 600 to 800.
That's exactly what we do. And I would say, so I guess to say this, 400 is your minimum when you're talking RadSeg, right? What were you
and
gonna say,
I think this is really important because I think they've both Zach and Sid have mentioned two really important things is, we're not talking your intent, right? Is your intent curative? We're doing a radiation segmentectomy. When you're thinking about radioembolization and, how, all the uses we have for it, curative intent is going to be to talk even if I'm going to target to the perfused territory or I'm going to dose to the tumor volume, we really have to think about that intent. We're not talking about patient selection in this specifically, but also Sid alluded to this, like which patient am I treating? So assuming you have appropriate patient selection, right? The patient has good liver function, good functional status, can tolerate the treatment. In this case, he's talking about a 3-centimeter tumor. You're going to get selective. It's going to be a radiation segmentectomy. I'm going to target to the perfused territory, and I'm probably going to target along, that's important, the minimum. So that threshold should be, we know that at least 400 gets us that complete pathologic necrosis, but we don't really know the ceiling. So I would say you at least have to target that. I tend to be just in the 600 range, just so I at least get 400. But so if you want to do a radiation segmentectomy for curative intent and you're getting really selective, then the rest of the liver that's not tumor there, it's pretty much expendable. So I tend to target those higher doses.
What are you worried about in the ceiling? So 2,000 gray to the area. What would you be worried that's going to happen?
I think two things. I mean, number one, is it necessary, right? Like, let's go to 10,000, 100,000. Like at some point, the tissue is going to be liquid, right? So you can't make it more liquid, right? Dead is dead. What have we seen? So we've seen, I think a lot of us who have done a good volume of this, once you do, let's say 1,000 patients, you start to see these very, very rare complications that happen in 1 in 500 or 1 in 1,000. So I'll give you a couple examples. We've seen a couple of fistulas where we've seen a fistula to the bowel in segments that were abutting, let's say, the stomach or the colon. How many times? We've seen this twice, and we've probably done over 1,000 radiation segmentectomies. So has it really changed our practice? Not necessarily. And in those cases, I would say the dose probably reached, in the ballpark of 1,000 gray or maybe even higher.
They weren't at Avastin, were they?
They were not. And we have had, I think you and I talked about this a lot in the past. We have had 1 or 2 patients on Avastin. They did develop that. And it might be due to the Y90, might be due to the Avastin, or both, or neither. Hard to say.
Or is it even related to the dose?
It might not be related to the dose. And because it's so rare, right, it happens when you have an adverse event that happens in less than 1%, it's hard to make a root cause analysis. Right? Because now if I say, okay, well, it's the dose, then I got to look at every patient that I treated, let's say with 1,000 gray, and I still find out that the vast, vast majority of them, 99% of them, did totally fine. So then should I really change what we do based on 1 in 1,000? And they eventually got better too. It wasn't, life-ending or anything like that. It's hard to make that justification.
Well, it's funny too. We talk about, I dose to make sure that I give a little bit of lung dose, have a little bit of lung dose left, right? When we're dosing at 2,000 gray, if you
your
put
lung
in
dose
so
will go
much
high.
activity, you got to be careful that you save some lung dose for the future, right? Because these patients inevitably, you can't, if surgical resection, if the likelihood of recurrence after surgical resection is somewhere between 50 and 70%, if we're doing something comparable to that, the likelihood of a new HCC popping up is not negligible. So I think saving lung dose is important. But we talked about perfused territory dosing, and this is a good opportunity to swing back to Zach, because ironically, somebody at this table recently published something looking at actual dose to tumor and what the appropriate dose to tumor was. How do you look at this, Zach?
So it's I guess a philosophy, right? So when we talk about radiation segmentectomy, that whole concept came out of trying to mimic a surgeon going in there and taking a segment out. And so what that is, at least in my mind, is complete pathologic necrosis, right? Yeah. So instead of it's still being in there and being complete pathologic necrosis, they just take it out, it's in a bucket, it's dead, right? So we're trying to mimic that. And so the goal with all of this dose escalation, right, is to get every single tumor cell dead that we're treating. Legacy was great because I think it, to some degree, started changing our thought process about it, where, before it was dosing to disease control or dosing to response rate, imaging response rate, where Legacy said, 400 gray, which was a subpaper of Legacy from the resection patients, was just those who had CPN, right? Complete pathologic necrosis. And so if we look at Legacy, it was 2 centimeter tumors with a, relatively more or less 2 centimeter tumors in a perfused volume, right? So maybe 400 gray was enough for that. But as the tumors get bigger, you probably need more radiation. And I think most of us have realized that, and that's why we've gone up to 600 or 800 gray to the perfused volume, because we realize that's a better target for that. And so I think the ultimate answer to your question of when do we stop dose escalating is when we have firm numbers for what actually gets us complete pathologic necrosis. And then we can, work backwards and say, do we need a multi-compartmental model to do that, or can we still do single compartment, just knowing that for bigger tumors, they need 600, 800 gray of the perfused volume. But I think starting to think about it in the surgical mindset of we need to get complete pathologic necrosis is going to help us, answer that.
Okay.